Good morning, everybody. Sabah al khair. A very warm welcome to all of you to this first webinar under the auspices of the International Academy for Clinical Hematology. It is a true privilege for us at the ICH to start this collaboration with the Egyptian hematology colleagues, especially our master and host today, Professor Hussam, who has been always a leader and a pioneer in the transplant field and in hematology in general. So, Professor Hussam, we are extremely grateful and privileged having you with us.
Thank you. The pleasure is all mine, sir.
With me on behalf of the ICH, we have Professor Florent Malard, who is an expert in GVHD, and we thought that this series of webinars dedicated to the transplant field, because you probably know that the transplant field has been moving dramatically in the right direction, because for many, many years, we have seen some stagnation, but in the last 5 to 10 years, we've seen the advent of haploidentical transplantation and the use of post-Cy, which has been a true revolution for all of us, and this is going to be the topic of today. We've seen also huge advances in the field of acute GVHD, and we will discuss this later. And more recently, some incredible advances in chronic GVHD, actually, especially with the approval of new drugs. And you may have seen 2 weeks ago the positive opinion in Europe about the ROCK2 inhibitor, belumosudil. We've seen also advances in supportive care. We've done a lot of work on VOD and the management of complications. New drugs are coming in TMA soon, so it's going to be extremely exciting. And last but not least, I think we are now clearly improving in terms of relapse prevention and the use of maintenance therapy after allo transplant. And of course, some novel venues are about combining transplant with the novel treatments, novel immune therapies with CAR T cells, etc. So really, the future looks brilliant for us in the field of transplant. And this is why I believe that this series of webinars is really timely, because sharing experiences together is probably the most important part in our field. And this webinar is a CME accredited activity. So, of course, after the webinar, you can claim your CME point delivered by the European Board of Hematology. So I'll stop here and hand the floor to Professor Hussam, our host today, for the introduction before moving to the presentations and discussions.
Thank you very much, Professor Mohty. It's always a pleasure having you with us. And I also like to welcome Professor Malard for being with us today, and thank you for joining us. Since the early days of bone marrow transplantation, it has always been the dream of transplanters to perform transplants crossing HLA barrier. And for many years, this was not possible, but with the advent of haploidentical transplants, it has become possible, and a dream came true. Thank God. Because now almost every patient is going to have a donor. In about 95% of the patients will find a suitable donor now. But the question which arises is the following. If you have many donors, for example, parents, children, siblings, how to select the most suitable donor? And this is the topic which we are going to discuss with you today. And it's a very important topic because the success of the transplant depends on this choice. This is the first webinar in a series of webinars which are going to come. The next one is going to be on acute GVHD and then one on chronic GVHD. So we'll start by a presentation from Professor Mohty about this topic, and then we will hear Professor Yasser Nahas about the experience in Egypt, and then we'll spend a few minutes on discussion. Professor Mohty, please.
Thank you again very much, and a very warm welcome to all the colleagues who have just joined. It's really impressive to have such a high level of attendance in a national event. It proves actually the motivation and enthusiasm and interest around these topics. The goal today is mainly to discuss, and this is why we will have most of the webinar dedicated to exchange and discussions and Q&A. So please don't hesitate. I thought to set quickly the stage by sharing with you, actually, I think a relatively common scenario to many of you in this room. And this is a 60-year-old male patient, CR2 AML, intermediate risk. He's, a big gentleman, 90 kilos, 185 centimeters. And if we look, and he's a candidate for transplant. I think there's no debate about this. So he has a sister who's 63, so slightly older, 2 pregnancies, and she is HLA compatible. She is CMV negative. He's CMV positive, but she is relatively thin, 65 kilos. Although I know it's very difficult for the patient in the Middle East to find unrelated donors, but we have a matched unrelated donor for this patient, a male who is very young, CMV positive, 72 kilos, and minor ABO incompatibility. But of course, the most important part is that he has 2 haplodonors. First of all, his brother, who is 55, slightly younger, no DSA, and we will discuss DSA. He is ABO compatible, CMV positive, and relatively good weight, 75 kilos. But he has also his son, who is 25, no DSA, ABO compatible, CMV positive, and, as big as him, 85 kilos. And actually, there is no right or wrong answer to this question. And let me walk you through, and we will discuss later what you are going to choose, which. So first of all, donor age when it comes to the selection process. Today, donor age is demonstrated to be an important parameter. And if you increase the donor age, you have lower survival. This has been shown historically, but also more recently, including in the haplo donor. You can see here the study from Dr. DeZern published 4 years ago. And there was a clear cut, and we have published also a study in the American Journal of Hematology, where we could show that a cutoff around 40 years. So below 40, you are young. Above 40, maybe you are less young. So clearly, even in the haplo setting, there is an impact on the age of the donors. And you can even want to push it further, but this is highly debatable, that if you have a young haplodonor versus an old matched sibling donor, maybe that would favor the haplo donor. So you can see age is important. The other important parameter, which I will not spend a lot of time, we need to accept the idea that more and more we see SHIP because the population is aging and the donors are aging, and we are transplanting more and more older patients. However, I would like to emphasize today that although we have data suggesting that maybe SHIP can correlate with chronic GVHD, and we'll discuss chronic GVHD in another webinar, actually there's no recommendation to use SHIP. Now, what about kinship? And for haplo, it's important because you have the parents, you have the children, but you have the brothers and sisters. So how can we navigate all this? So in general, in the haplo setting, and we published this also a few years ago, the parents donors, the parental donors, have likely worse outcome. And you may tell me this is because the parents are by definition always older. And this is maybe true, actually. This is maybe true. And if you even focus on the parents' mothers, especially if it is a mother for male patient, actually, again, the outcome is worse in terms of progression-free survival or GVHD-free survival. And we know the impact of a female donor to a male donor. So you can see the picture. To be honest, when we looked in the EBMT registry, and this is a paper we published 3 years ago, we didn't see a clear correlation. But if we consider, if we put into account the patient age, the donor age, but also the kinship. But obviously, you can see that the parameters are around whenever possible, favoring the young, favoring the male, it's better. So speaking about gender, it is well known, and it's still true today, that a female donor to a male recipient, this is the worst scenario because you have increased GVHD risk. And this is also true more recently, 10 years ago, it was shown. The worst scenario is, you can see here in red, when it comes to chronic GVHD, a female donor to a male recipient. And we're talking about thousands of patients here. The best scenario would be the blue one, male to male, then male to female, the green, and then female to female, of course. What about ABO compatibility? Well, I must confess that historically, ABO compatibility was problematic because you know that incompatibility, major incompatibility may lead to delayed red cell engraftment, pure red cell anemia. Although now, with some of the recent drugs like daratumumab, maybe we can solve this problem. Minor incompatibility can lead to acute hemolysis, delayed hemolytic reactions. But in general, this is about non-relapse mortality. In the haplo, because this is our topic today, actually, if you're using bone marrow, which we are not using anymore in the adult, maybe in pediatrics, a different story, this is where mainly the ABO mismatch will play a role. Otherwise, in general, with PBSCs, the story is simple. Now, CMV serostatus. Again, we know very well that CMV will play an impact on transplant-related mortality. And if you use a CMV negative donor for a CMV positive patient, it can be problematic. We'll have to discuss this because I don't know exactly how the situation is in Egypt for letermovir, but if we use letermovir prophylaxis to everybody, actually, CMV story is an old story. It's not. Last but not least, actually, this is about DSA. donor selection and donor-specific anti-HLA antibodies. If there is today one parameter to take into account, if I have to choose only one, actually, this is about the DSAs, because the DSAs, the presence of DSAs is correlated with transplant-related mortality, with delayed platelet recovery, delayed neutrophil recovery, and of course, the worsened outcome. But of course, not all DSAs are equal. And we will discuss this, but the MFI, the mean fluorescence intensity, is going to play a role. And this is why we have, in principle, if we have other choices, to avoid the use of donors where we face DSAs. This is clear. I think it has been shown in haplo, in cord blood transplant. So we have to reconsider this. Of course, we can discuss desensitization, but I'm not convinced that this is very practical. It doesn't work most of the time, to be honest, and I'm not sure this is something we would like to recommend. So with all of these parameters, I think if we are using PBSCs in the haplo setting, the idea is to try to favor the youngest donor, avoid the female to male, and most importantly, look into DSAs. But there are other parameters that I didn't discuss, which I think are important, the psychological consideration, because we're talking about family donations. So they know each other. And obviously, if you have a mother donating to a son or to a daughter, and the transplant goes wrong, you would imagine the implications. On the other hand, if you have a child donating to parents, usually parents give life, not the other way around. So you would imagine all the problems that can arise. So for the sake of time, and as I told you, the idea is to favor discussion, I will stop here and now hand it back to Professor Hussam for the moderation.
Thank you, Professor Mohty, for the illuminating informations. And I will now ask Professor Yasser El-Nahas to step forward and give his lecture on how to select a haploidentical donor, and then we will spend some time for the discussion. Thank you.
Thank you very much, Professor Mohty, for this very elegant presentation. You made my lecture easy. If you excuse me for my English, because I am a French speaker too, so I will try as much as I can to present the common practice here in Egypt according to haploidentical stem cell transplantation. So I will start by saying that haplotransplant is a potentially curative therapy for different hematological disorders, whether benign or malignant. And with the tremendous improvement in this approach, it has been now considered as a standard option and not a last resort. The donor shares one HLA haplotype with the patient and differ with the patient for a variable number of alleles on the unshared haplotype. We usually use it when we do not find a matched sibling or unrelated donor, and it has expanded the donor availability for most of the patient. Over 90% of patients have now a family donor. These donors may be biological parents, children, siblings, or even more distant relatives like cousins and grandchildren. This approach requires careful donor selection to optimize engraftment, GVHD, and survival. So of the advantages of haplotransplant is the fast access and reaccess to the donor, the better engraftment kinetics, better than cord blood, the better GVL effect mediated by NK alloreactivity, and definitely the lower cost from finding a matched unrelated donor. Some complications are the high graft failure rate that are mediated by recipient, antibody mediated, or the high rates of GVHD, mainly mediated by donor alloreactive T cells. In Egypt, and according to somehow a large retrospective studies, we could find that nearly 55% of our patients could have an HLA matched sibling donor transplant, making this kind of transplant the most common in Egypt. So the algorithm for donor choice in adults who are in need of transplant in Egypt is the first choice is to find a matched sibling donor, which we can find in 50% or more of our patients. However, the usual scenario, and if we lack the presence of a matched sibling donor, is usually a haploidentical related family donor with special considerations. So key selection criteria in the lab that we use to see are the recipient donor-specific antibodies, some HLA compatibility and mismatches consideration, donor age and gender, CMV serostatus matching, ABO compatibility, Kierligin mismatching, medical fitness and availability of the donor. Non-inherited maternal antigen mismatch may be better tolerated than a non-inherited paternal antigen. However, this effect has been quietly abrogated by the introduction of post-transplant cyclophosphamide as a GVHD prophylaxis regimen. So as Professor Mohty said, donor-specific antibodies are antibody-mediated graft rejection that may occur either by antibody-dependent cell-mediated cytotoxicity or complement-mediated cytotoxicity. These are recipient DSA against mismatched donor HLA antigens that leads to an increased graft rejection risk. They are mainly associated with graft failure, delayed engraftment, and poor survival. We test them using Luminex, single antigen bead assay, and using microspheres coated with specific HLA antigens to detect class 1 and 2 antibodies with high sensitivity. And the results are expressed as previously said, mean fluorescent intensity, which is a term mainly used in flow cytometry. So all what we need, this is a kind of virtual cross-match to predict graft rejection risk. All what we need for the patient is its HLA typing and the HLA antibodies. And all what you need for the donor is its HLA typing. So we identify antibodies against donor HLA mismatches. We rank donors. Those according to the less MFI are the best acceptable. We may accept non-complement binding DSA with less than 2,000. However, some studies said that stated that with DSA over 2,000 MFI, there may be an increased risk of graft function and subsequently outcome of the haplotransplant and survival. We had put a cutoff 5,000 MFI for high-risk graft failure. In this case, we may choose alternative donors, or if unavailable, consider desensitization. So the clinical relevance by DSA testing in benign hematological conditions like aplastic anemia and thalassemia, those patients who are highly transfusion exposure will be highly alloimmunized, leading to primary graft failure. Likewise, in sickle cell disease, multiple RBC transfusion will end by a high recipient DSA risk, leading to an engraftment failure. In inherited immunodeficiency, possible maternal antibodies may lead to early graft loss. And in acute leukemias like ALL and AML, some transfusion pre-transplant may lead to moderate risk of delayed engraftment and poor survival. In MDS, also chronic transfusion will lead to anti-HLA formation and graft failure and poor chimerism, especially in reduced intensity conditioning for older patients. Some HLA considerations, we look to HLA AB, CDR beta 1, DQ beta 1. We may consider, according to guidelines, DR beta 1 mismatch, DQ beta 1 match. These carry the highest disease-free survival. Non-permissive DP beta 1 T cell epitope mismatches, although it increases GVHD, but it also increases graft versus leukemia and improve overall survival in hematological malignancy. C locus mismatches are associated with higher risk of chronic GVHD. So in haplo, under post-transplant cyclophosphamide GVHD prophylaxis, it's not the number of HLA mismatches on the unshared haplotype that predict GVHD or survival. Rather, there are defined locus-specific characteristics of HLA mismatches that inform survival, and they can be improved by B-leader matches, mediating a status of NK-mediated alloreactivity, DR beta 1 mismatches in the GVH direction, which are mediated, leading to a T-cell, donor T-cell mediated alloreactivity, lowering the risk of relapse, and non-permissive DP beta 1 T-cell epitope mismatches, which are going into the GVL direction, improving overall survival. This is an example in our institute of how to consider all HLA and non-HLA factors for a TLL patient awaiting for transplant. He has two donors. Donor 1 is 7/12 match. Donor 2 is 28 years old, but 6/12 match. Both donors had a negative recipient DSA. Leader matched C locus. They both share a one locus C locus mismatch, and DR beta 1 mismatch was in the GVHD direction for both donors, as both donors were homozygous for DR beta 1 locus. However, the DP beta 1 permissiveness gave us for the first donor a non-permissive host versus graft effect. But in donor number 2, it was a non-permissive GV graft versus host effect. So in this consideration, we may look for donor 2 who have more mismatches on the unshared haplotype, who is just 6/12 match as a potential donor. This is an TLL patient in second remission, and we may need the GVL effect. And as Professor Mohty just said, we may prefer younger donors due to lower incidence of GVHD and better engraftment. Male donors also are preferred. We are trying to avoid female to male as much as we can. And then a very important consideration in older donors, as just said by Professor Mohty, trying to avoid clonal hematopoiesis carried by older donors. So this is an important issue. And the best outcomes are better given by patient and donor matching for CRV serostatus, with best results in CMV negative patients allografted from a CMV negative recipient. Other non-HLA considerations, ABO mismatch is usually acceptable, especially by the use of peripheral blood as a stem cell graft source. Donor health and availability are important. Infectious disease screening, especially in Egypt, HCV. In the setting of a bone marrow graft large patient to donor weight discrepancy are avoided. And in case of myeloid germline predisposition variants, there are critical considerations in related donor selection, especially if the recipient is a carrier. Maybe selecting a distant relative or an unrelated donor will be generally preferred. So an example of ranking donors are donors against which the recipient DSA is negative, younger donors, male gender is preferred, CMV serostatus matched, looking to some HLA considerations as B leader match, DR beta 1 mismatch in the GVHD in the GVL direction, and DP beta 1 mismatch in the GVL direction too, and trying as much as possible to have a clear mismatch, and this mainly work in AML. It has been stated that optimizing stem cell dose also can affect the outcome of transplant. So for peripheral blood as a stem cell source, we use 2 to 4 million per kg body weight patient. We infuse in bone marrow 2 million per kg body weight patient. In haplo, we may increase the stem cell dose to 5 times 10 to the power of 6 per kg body weight donor, as lower CD34 donor cell dose are associated with worse overall survival, especially after post-transplant PSI. Some special situation in non-malignant disease, bone marrow may be preferred as a stem cell source. Haplotransplant with post-transplant PSI reduces GVHD, improves outcome, and in urgency, haplo donor are fastest to access if no match-related donor is available. So as a practical donor algorithm in malignant disorders, we check usually for a match sibling donor. If no, we may discuss with the families the possibility of searching for a match unrelated donor in international registries. However, the usual scenario ended by considering a haplotransplant after discussing with the family if the patient has negative DSA using peripheral blood as a stem cell graft. So various graft engineering strategies have been developed lately, use mainly post-transplant as an unmanipulated, but in unmanipulated CD34 positive selection and T cell depletion by depleting alpha beta T cells and expanding T regulatory cells or cord blood expansion have been invented. We usually use unmanipulated haplotransplant with post-transplant cyclophosphamide as a GVHD prophylaxis regimen. The possible mechanism by which GVHD works in haplo is destruction of alloreactive T cells of the donors. And this was supported by data from the CIBMTR that showed that in the registry, more haplo were using post-transplant as a GVHD prophylaxis were against other GVHD prophylaxis regimen. In addition, data from the EBMT also coupled with the data of the CIBMTR showed an increasing trends in haplotransplant over the last years, and maybe haplotransplant with this tremendous improvement, the curve may approach the match-related sibling donor transplant, as we can see in the CIBMTR data. Many questions in our clinical unit are usually asked according to patient-related factor, disease biology, risk, and control. Is it to use a myeloablative conditioning regimen with a lower relapse rate, or to use a reduced intensity conditioning with a lower GVHD and transplant-related mortality? In addition, what is the best stem cell source? Is it a bone marrow with a little bit increase in graft failure, or a peripheral blood as a stem cell source with its higher 1 log T cell content, but associated mainly with more chronic GVHD but lower incidence of relapse? And data from the SBMT have shown that regarding haplo bone marrow versus peripheral blood, no difference was seen in engraftment kinetics in terms of neutrophil and platelet recovery, as well as also in outcomes in terms of acute and chronic GVHD and relapse-free survival. They stated that haplo using peripheral blood stem cell may have a lower incidence of relapse, a lower incidence of non-relapse mortality, and better overall survival. And this data also has been supported by the EBMT recently, showing that haplotransplant using peripheral blood stem cell has multiplied significantly in recent years. So all data are nowadays going for haplo with peripheral blood stem cells. For us, some AML and MDS donor selection, we usually prioritize a matched sibling donor, but the scenario may end with a haplo donor due to the lack of a matched sibling donor. In AML with high-risk genomics, we prefer a matched related donor, but a haplo is pretty much acceptable with post-transplant, especially when urgency is needed, taking into consideration HLA-DP-BDR1 mismatch in the GVL direction, and younger donors are strongly preferred, especially in haplo MDS. So you all know that in MDS, patients the related donors are old, so it may be preferred to use in haplo for MDS biological children that has a younger age. Some special consideration in high-risk genomics as FLT3 ITD positive AML, a faster transplant, haplo is acceptable if MUD is delayed. In the setting of a prior allo stem cell relapse, we may prefer a new related donor and avoid the original haplo donor. In relapse after haplo, evaluation of HLA loss and selection of a donor mismatched to the retained HLA haplotype is a logical strategy to enhance the GVL effect. And in special situation that we don't like much, like active disease at transplant, peripheral blood may be preferred for GVL effect. In ALL, we also prioritize matched sibling donor. Haplo with post-transplant is highly effective. The ABMT registry-based analysis showed comparable results for all types of donors. Haplo has very promising results conferred in pediatric ALL receiving graft from an alpha-beta T-cell depleted graft with a lower risk of non-relapse mortality and both acute and chronic GVHD. For Philadelphia positive ALL, donor choice are less critical due to TKIs. We prefer a match-related donor. Most of children with ALL will receive TKI for at least 2 years after transplant for relapse prevention. In MRD positive ALL, we may prefer peripheral blood as a stem cell source. We use Chimera and MRD strongly to predict the risk for relapse in children. In TALL, we may prefer peripheral blood as a stem cell source for stronger GVL effect, and as much as I can avoid female to male donors, as previously said by Professor Mohty, if other donors are available. In myelofibrosis, the donor priority are usually a matched sibling donor to avoid high HLA mismatches. Bone marrow is preferred in cases of severe splenomegaly. Splenectomy is an option to reduce spleen size prior to transplantation. The European Leukemia Net and the ABMT recommend the use of ruxolitinib at least for 3 months prior to transplantation, 2 to 3 months, to improve constitutional symptoms and reduce spleen size, taking into consideration the weaning of ruxo to avoid relapse phenomenon. For myelofibrosis patient, we see that those who achieve molecular remission after transplant or those who show a total resolution of their bone marrow fibrosis have the best long-term outcome after haplotransplant. And in aplastic anemia, the donor selection is mainly a matched sibling donor, trying to avoid as much as I can peripheral blood as a stem cell source. We prioritize age, lower age, and CMV matching as important, and we prefer young male donors. The goal is to minimize GVHD, and the Baltimore group have showed promising results using haplo-post-transplant in aplastic anemia. For thalassemia, there is a low probability of finding a match unrelated donor in some ethnicities. New strategies are employed to develop an effective and safe haplotransplant for transfusion-dependent thalassemia patient. We prioritize matched sibling donor. Haplo with post-transplant is now feasible, but requires strict conditioning experience centers. We may prefer younger donors. However, we try to avoid as much as I can cord blood as a preferred stem cell source. Likewise, in sickle cell disease, as stated by the ABMT, the probability of finding an 8/8 HLA matched unrelated donor is less than 18%. We prefer matched sibling donor, allografting from a bone marrow as a stem cell source due to lower GVHD and mortality. Haplo has been emerging with post-transplant as an in vivo T-cell depletion strategy. Many centers now considering acceptable, and we try to avoid as much as I can peripheral blood due to association with chronic GVHD. So the main motive in Egypt and our experience in haplotransplant started due to the lack for like 50% of our patients for matched related donor. And it is well known that a lower percentage of donors are listed in the international registries. They are from Oriental origin, in addition to the cost also. So the problem has been largely solved by the introduction 9 years ago of our haplotransplant in the clinical transplant unit. The program started 9 years ago. We allografted more than 500 patients until now. Most of the conditions were for malignant hematological disorders. However, 1/3 of the conditions were haploallografted for benign conditions, mainly in the pediatric unit. We used conditioning regimens between myeloablative and reduced intensity, depending on disease biology and several patient-related factors. The main stem cell source was peripheral blood. The GVHD prophylaxis was post-transplant in addition to a calcium urine inhibitor and mycophenolate mofetil. As regards of outcome, we had a graft failure of 5%, a relapse of 9%, an acute GVHD of 7%, and a survival at 1 year. The overall survival was 66%, and the disease-free survival was 56%. So in summary, the recipient DSA, donor age, and HLA considerations are important tools for haplodonor selection. There are different underlying mechanisms through which HLA-DR beta-1, DP beta-1, and beta mismatches influence the clinical outcome after haplotransplant with post-transplant PSI. The effect of these HLA mismatching in the GVH direction depend on the mismatched locus. HLA-DR beta-1 mismatches decrease relapse, and non-permissive DP beta-1 mismatch decrease mortality and increase GVL. HLA B leader matching lowers the transplant-related mortality and improves overall survival. So haplo with post-transplant PSI is now a strong alternative across diseases, emerging as a first type of transplant for a wide variety of malignant and non-malignant hematological disorders, especially in case of an urgent need for transplant. Optimizing donor selection have made haplo a viable strategy with continuing improvement in outcomes. And I would like to thank you very much for your attention and thank the teams for the NCI, the NIH, for providing me many clinical slides. Thank you very much.
Thank you, Professor Yasser, for showing the Egyptian experience in haploidentical transplants. And now we have some time to discussion. And in Professor Yasser's slide, one of the first slides was stating that haploidentical transplants would lead to a higher GVHD incidence compared to matched sibling transplants. And in the post-PSI area, I would like to challenge this statement because, as you have seen in our experience, the incidence of acute and chronic GVHD with the post-PSI transplants is not very high. I don't know how the situation is in Paris.
Yeah, no, this is, well, first of all, congratulations, Professor Yasser, for really beautiful and comprehensive talk. And also congratulations for the large series that you have published, Professor Hussam and the colleagues from about more than 500 patients. This is impressive. So I agree with you, Professor Hussam. I don't believe we see more GVHD with haplo today if we use post-PSI and the usual cyclosporin MMF. And in our case, and Professor Mallar can comment on this, in some, we also add ATG, a small dose of ATG. So clearly, when we add ATG, we have even lower GVHD than traditionally. But I agree with you, GVHD remains a problem. And by the way, today is the GVHD Awareness Day, 17th of February, all over the globe. And maybe if you allow me, Professor Hussam, at the end for the conclusion, I will show you the ICH message for the GVHD awareness. So you will get it a few minutes before the official release.
Okay.
So actually, going back to this, no, I agree with you. I think GVHD remains a problem. We have still, for instance, 30 to 40% of the patient getting acute GVHD, if not more. But also we have 20% at least having chronic GVHD that requires treatment. But maybe Professor Mallar would like to comment on this.
Yeah, so thank you. I would like also to thank you, both of you, for the great presentation and that provide a good overview. But this is also very interesting because it allows us to discuss and to see that we are, and to see how we can adjust and by working together, just improve our practice, your practice, but also our practice. Regarding the PTSI, I confirm what Mohammad said. We have some great results, including without the ATG. With this PTSI platform, we have very low incidence, in particular of chronic graft-versus-host disease, but also of acute graft-versus-host disease. On several studies that have been conducted that compare the ATG with the PTSI, and now more and more people are using the PTSI for the match-generated donors, of course for the mismatch-generated donors, but also in some centers for the match sibling donors with comparable result with the ATG when we use peripheral blood stem cells. So the PTSI seems to be the standard of care for haplo, for mismatch-generated donors. And if you can't use ATG, it can be the standard of care for match sibling and match-generated donor with low incidence of graft-versus-host disease.
Thank you very much. Another topic which is important to me and I would like also to know your opinion about it. We are all testing, of course, for DSA, but what about C1Q? Is everybody testing for C1Q?
My
No, we are
short
not
answer is
using
no.
C1Q. No, we just do DSA. So there is very few people that are doing that, but we not on a routine basis.
And according to what we have seen from the lecture of Professor Yasser, that things are becoming more complicated in the choice of a haploidentical donor. So if you look at DR beta 1, DQ beta 1, and the DP permissiveness, and the C locus match or mismatch, I know this is done today by a software, and the software would tell you what the best donor is. But what is the situation if the donor choice which comes out by the software is not the best donor clinically? I mean, in terms of age, in terms of CMV, in terms of
So
LEO stability, what do you do then?
So I will go for the clinical parameters because of now you know that we can have some software that will provide some good result, but it is always based on some kind of probability, of course. And here we have the situation where you have it's not probability, it's about the choice of the donors. On CMV, this is key parameters. And if you can't do any prophylaxis with letermovir, it's very important to choose the CMV positive donors for the CMV positive patients or the CMV negative for the CMV negative recipient. This is very important. Donor age is also important. If the algorithm say, yeah, you have to keep to take the father that is 70, it's not a good idea for a clinical point of view, and we'll take maybe the children of the brother that are much more younger. So I think clinics is come first. On after, if you have the choice with two perfect donors, you can use the algorithm to select which one will be the best one.
Another technical topic to me, which I also would like very much to discuss with you, is the desensitization. If you have a high DSA and the desensitization. At the beginning, we were doing desensitizations, and basically with rituximab, plasma exchange, and in some cases of bortezomib also. But what we have seen, yes, you don't get graft rejections, but what you get is severe infections when the patient is already at home. Fungal infections, reactivations of CMV, and the mortality is higher in such patients. So what is the experience in your center?
So, just I have one question first. At which level it's of MFI did you use desensitization? Because this is
5,000.
5,000. So are doing the same. This is the threshold we are using. And so we are still doing some kind of desensitization just to avoid the risk of graft failure. But yes, we are going to induce with the bortezomib, with the rituximab and so on, some B-cell aplasia that will be much more severe in those patients. That is probably the explanation for this severe infection. So of course, you can say that maybe we need some more prophylaxis, some more monitoring, but we know that it is not always easy to have the patients to come more often at the hospital after. One alternative will be to do not do any desensitization, but to use some very high doses of CD34 just to increase the chance to achieve some engraftment, but we'll still have the risk of graft failure for those patients. So there is no good answer to that question. What I will advise is, yes, try to desensitize and just to do some better monitoring after, but I know this is not easy to have this kind of more monitoring of the infection after just to avoid them.
Well, what I did, to tell you the truth, is that when I found this problem, I increased the peripheral blood stem cell dose and I omitted the desensitization, and it works it actually pretty well. And since we have anyway a low incidence of graft versus host disease, I took the risk of increasing the graft versus host disease incidence a little bit, but avoiding the graft rejection, because there is nothing worse than having a patient with graft rejection. Then you have him in the hospital and you don't know what to do with him, which is a
So
very
yeah, Yeah, so yeah, put high dose of CD34, more PBSC, and it seems to be a good alternative if you're indeed.
Now, if you cap, if you do the sensitization, do you cap the peripheral blood count?
Yeah, we are doing like you are doing like we are doing for other patients with some cap, but when we desensitize.
No, I mean, how much do you give? If you, for example, collect 14 millions, how much do
We
you
are
give
cap at 10 million, Mohammed, if I remember well.
at
Yeah.
10 million? You
Yeah.
cap at 10 million, which is, of course. And what about, I mean, one of
So let me comment on this issue of the capping, actually. This is a historical concern. I must confess that in the haplo setting, we don't have as strong data as in the past. But you may remember that when we started doing PBSCs in the 90s and 2000, and we've published even a meta-analysis about this in the early 2000s in JCO, we found that the 8 million threshold is the threshold we need to take into account, especially when it comes to chronic GVHD. That was really the main problem, because we had better engraftment, we had better hematopoietic recovery. So we extrapolated that in the haplo setting, maybe between 8 and 10 would be our, let's say, best scenario. But again, this is pure empirical. I'm not aware of prospective randomized data on this. And here I'd like to remind our colleagues, if Professor Hussam allows, that they can open their camera, they can open their microphone, and they can ask questions, you know.
Yes, we are going to give them time for this. And I'm going just to discuss one more topic, which is the cytokine release syndrome, which is the whole core of the haploidentical transplant is the cytokine release syndrome, and we learned that the hard way. And usually it comes with the infusion of the stem cells, and then again with the introduction of the post-cy. So what is the situation at your center, and how do you deal with it? Do you give Actemra routinely, or steroids first and then Actemra, or what do you do?
So the thing is that for most patients, we use a low dose of ATG before the transplant and have combined with the PTCy. So given we give low dose of ATG, we have less cytokine release syndromes in our patients. But of course, we can't recommend, it's not feasible for everybody to combine ATG plus PTCy. Nevertheless, we have some patients that receive PTCy alone, and we start the calcineurin inhibitors on mycophenolate mofetil on day +5, so after the PTCy, and they have cytokine release syndromes with high fever. So most of the time, we try to monitor them, and when we infuse the PTCy, the CRS is going to resolve, and we don't use anakinra routinely in our patients. In fact, we're just monitoring them very closely and wait for the PTCy just for the fever to improve. Of course, if you have some very severe form, but it is not the case, we don't get that, you can use steroids, tocilizumab, and anakinra, it can be discussed, but of course, we are always afraid of the infectious side effect of these treatments. So.
And what about the conditioning regimens? I mean, the conditioning regimens are very important in the haploidentical transplant.
So usually we use a TBF platform with 1 day of thiotepar, 5 milligram kilo total dose of thiotepar, busulfan for 2 days of busulfan. So we use IV busulfan for 3.2 IV, but this is 4 milligram per kilo oral busulfan equivalent. So for 2 days of busulfan combined with fludarabine for 5 days of fludarabine. So it's supposed to be some reduced toxicity conditioning regimens. It's not the classical myeloablative. And of course, if you are using some very myeloablative conditioning regimen, you expect probably to have more CRS before the PTCy. So that may be also the reason we have less CRS in our experience.
We used to use flu-BuCy and TBI for most of the patients, except if they are very young and malignant, then we give the BuCy, or in aplastic anemia, Flu-Cy also. And it works, by the way. And it works, by the way. But we are now, because we want to avoid the TBI, we are now going to shift to what you are doing, to the TBF, because logistics of the TBI is always a problem in our center.
So for us, we have the same issue with the TBI. So
Yes.
just we are on the same side for the TBI. On just for the TBF, because we try at one time to do 2 days of tiotepa, so 10 milligrams. And in fact, in our experience, it was highly toxic. So we don't use anymore the 2 days of tiotepa. On 1 day of tiotepa is enough to allow the engraftment with some haploidentical donors. So, but we can discuss it further.
Yes.
Yeah, so let me comment on this, because tiotepa is really a great drug for haplo and for engraftment, because it's a very special alkylating agent that can mimic the activity of TBI. Actually, if you don't have access to TBI, you can use tiotepa. Busulfan cannot replace TBI. Tiotepa can replace TBI. But the problem, tiotepa is highly toxic for the gut. And then it generates a lot of acute gastrointestinal GVHD. And this is why we have drastically reduced the dose, which is, I think, good news for everybody.
And for the skin too, I think.
Yeah, and absolutely. Of course, the skin, you become black. If you start being white, you can become black.
That's for the skin. Do we have questions from the audience or from the participants? I would like to invite you to can you see any questions, Yasmin? Just a moment, we are searching.
Dr. Hassan, do you hear me?
Yes.
I'm
Yes.
Ahmed Ibrahim, Professor of Pediatric Oncology, Stem Cell Transplant at National Cancer Institute and the Children's Cancer Hospital of Egypt.
Hello.
Thanks all for this very nice discussion. I will go back question for Dr. Hassan, for Dr. Mu'ti, because as by the EBMT criteria or recommendations for donor-specific antibody, it was recommended that for any donor-specific antibody more than 1,000, we should check for the C1Q. Do you still recommending C1Q testing for the donor-specific antibody for more than 1,000? And my second question, specifically, when you go for desensitization, is the cutoff is 1,000 or 3,000 or 5,000?
So,
would you like to comment?
Yeah, so first of all, we don't check for C1Q. And as mentioned by Professor Malar, and he will comment on it, we would rather use the 5,000 cutoff. But Florent, maybe you would like to.
Yeah, we usually use the 5,000 cutoff, and for the C1Q, in fact, the story behind being this in the recommendation is that one people that is part of the recommendation was doing it in your lab, was fond of C1Q and say everybody is supposed to do it. But in fact, almost nobody is using it. And when we discuss with your colleagues, for example, that do kidney transplant, this is not also validated in this setting. So nobody is using it in France.
And no, and even in the United States, I have talked to many of the colleagues in the United States. They don't use it.
Yeah, only one guy in the US, the one that wrote the recommendation, in fact.
And the level of 5,000, I think, is reasonable, because if you put it at 1,000, then you will have problems. I mean, you will hardly find a good donor at 1,000. Any other questions?
Regarding if for a patient of who have a poor graft function or primary graft failure and haplo setup, what do you do regarding do you screen again for donor-specific antibody to see if it is antibody-mediated rejection or graft failure or it is cell-mediated type? So if do screen again for donor-specific antibody, or just we go for some sort of immunomodulatory conditioning like flow ETG or flow cyte to deplete the T cell, and you go for the redo transplant?
So what we used to do in those patients, so this is some patient with with engraftment, so we have some good chimerism, but we have some poor graft function with cytopenia. In those patients, we don't check for the DSA, but what we used to do is that we collect again only some CD34 stem cell from the donors, and we reinfuse them with no conditioning, any conditioning, just the CD34. So we have to deplete the T cells, the lymphocyte. And in fact, we have some good results. We do that maybe 5 or 6 patients per year because this poor graft function is very frequent after haplo with SPTSI. And it works. It has been published, reported. So this is what we recommend to do if this is feasible. Of course, there is a question of the cost because you need to select the CD34. And I know it costs money, but it seems to be the most effective strategy.
How do you select them on a Miltini column or what?
Yeah, Milteni column. Yes.
Oh, yes. We don't do this. What we do is we collect CD34, peripheral blood stem cells, and precondition again with fludarabine.
Just to get rid of the lymphocyte. Yes. So it can be an option, of course.
Yes, of course. This is what we do. Yeah, there is a comment from Professor Yasser.
Yes, for regarding the question of Professor Ahmed, especially in the pediatric transplantation and the pediatric unit, when you have no DSA and you have a poor graft function, you also may look to what we call maternal microchimerism, because especially in the pediatric patients, because this kind of maternal microchimerism and these cells from the mother that persist in the fetus and in the pediatric patient may lead to a status of poor graft function, especially if you have no DSA. And in addition, the T cells from the mother that persist in the young population, in the pediatric population, they also may lead to a status of T cell rejected T cell kind of rejection. So especially in the pediatric unit, these issues of maternal microchimerism and T cell rejection mediated by T cells that are very immunocompetent from the mother may be a special issue to discover or to look for, especially if DSA is negative.
Okay, thank you. Do we have any other questions from the audience?
Yes, Dr. Hussam.
Yes, please.
I am Ahmed Yusri. I am Ahmed Yusri from Nasser Institute, Hematology and Bone Marrow Transplant.
Hello, Ahmed. How are you?
How are you, Dr. Hussam? I just want to ask, if I have an AML patient with positive MRD, should I choose a suitable haplo donor over a matched sibling donor for the possibility of more GPL effect or no difference?
Oh, this is a difficult question. Would you like to comment?
Yes. Well, I think you're raising a very hot topic in our field, and we hear it more and more. The question is, until now, and our community is, I would say, rather conservative. Also, we are very innovative. You will see that maybe majority of people, of colleagues, will tell you they will focus on sibling donor. Now I can tell you the idea of having better GVL effect with haplo is always around. In our practice, for the time being, we didn't decide on such approach, but this is something that we need to explore.
I mean, it's a deal after all. I mean, the sibling transplant is safer, but maybe because of the MRD, you will get a relapse. And on the other hand, the haploidentical transplant is more risky, but with less relapse. It's the same discussion like the allo-auto in the past.
I think you are absolutely right, Professor Hussam, and the question is whether we want the problem immediately or later. But in our environment, I don't know how is it in Egypt, we have an added problem. Assuming for whatever reason, something goes wrong with the patient and family complains. And, you know, now they go easily to legal, blah, 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 courts, etc. And they complain.
The ChatGPT, sir.
Yes, exactly. So, and here where we can be stuck, because actually, if whoever asks and they say, why did you choose the haplodonor while you have the sibling donor? Then we are stuck, because everybody would say, oh, you should have chosen the sibling donor.
Yes, okay. Other questions?
Sorry, Dr. Hussam, just other question.
Yeah.
In this era of haplotransplant with using post-Cy, should I still use myeloablative conditioning, which was high toxic effect in all haplotransplant patients, or should I move to less intensity protocols?
I'll tell you what we do. We give flu-BU-Cy TBI for all patients except for very young patients who are high risk of relapse. Then we give the usual BU-Cy. This is what we do. I don't know what Professor Mahdi does. Or Professor Malar? What do you do in this situation?
So for us, we are not using BU-Cy anymore in any patients. And we don't use TBI. We only use TBI for patients with acute lymphoblastic leukemia. And in those patients, we reduce the TBI from 12 gray usually to 8 gray. So not the classic conditioning regimen. For the other young patient, when we want to use a myeloablative conditioning regimen, we use a reduced toxicity platform with the fludarabine on 4 days of busulfan in case of a sibling or a match unrelated donors. As soon as we have an haploidentical donors, we add Tiotepa.
Yes, but the TBI which we are using is not the usual TBI. We give only 400. It's one session low dose TBI. It's not.
Okay, so it's low dose TBI in those patients.
Not low dose TBI, yes, of course.
Yeah.
Any other comments, questions?
Dr. Hussam, Ahmed Yusri again, sorry.
Yes.
Regarding the conditioning regimens used in multiple myeloma and lymphoma who are going to be transplanted haploidentical, what is the best protocols regarding these patients in this era if no available CAR T cells or bispecific antibodies in our institution? So what is the best protocols for these two types of patients?
I mean, is anyone transplanting multiple myeloma haplo? I mean, I don't think so, because in the era of bispecifics and in the era of CAR T, the haploidentical transplant for multiple myeloma is quite rare. But for lymphoma, it's a viable option, of course. What we usually do is the same like what we do, flu-BU-Cy TBI, and this would be enough, I think. Professor Malar, Professor Mahdi, please.
So yeah, for the lymphoma, we use the same conditioning regimen. In fact, this is haplo. We use Tiotepa and busulfan fludarabine. And what we use also, because for lymphoma, this is frequent that we are not in complete response, and we use this so-called sequential conditioning regimens platform, the TechRic platform, to have some cytoreductions of the lymphoma before having a flu-BU conditioning regimen. So we include Tiotepa in this sequential conditioning regimens, amzacrene, cytarabine, just to have some more anti-lymphoma effect. Regarding the myeloma, we don't do any allo in myeloma now. And even before the CAR T and the bispecific era, we stopped doing allo in myeloma because we have too high non-relapse mortality. And in fact, if we want to be effective for myeloma, you need some very myeloablative conditioning regimens to be effective and this is too toxic for the patients. So we have too many infectious events after, so we completely stopped to do that. And it was not because we have CAR T and be specific now, because we stopped doing that even before we have these treatments.
Okay, for the sake of time, I now would like to invite Professor Mohty to put the video on GVHD awareness. please.
Yeah, no, thank you very much. That was not part of the plan, but I thought when I was looking to the date where we were talking, I thought so. We will diffuse this 1-minute video later today by the ICH, but I can show it to you now. So maybe I can ask the team to broadcast it. Today, we stand for GVHD Day. On behalf of the International Academy for Clinical Hematology, the ICH, we honor the strengths of patients and families living with graft versus host disease, and we salute the dedication of nurses, physicians, researchers, all healthcare professionals working to improve outcomes every day. GVHD is part of many transplant journeys, but so are resilience, innovation, and hope. By raising awareness, supporting research, and listening to patient voices, we move closer to safer transplants and better lives. Together, we care. Together, we progress. Together, we bring hope.
Thank you very much. And I would like to remind the audience that there are still a series of webinars coming in the nearby future dealing with the topics of acute and chronic GVHD, and I would invite you all to join these webinars in the nearby future. On behalf of the colleagues here in Cairo, I would like to thank Professor Mohty and Professor Malar for their participation and sharing experience with us. It was very illuminating to us and very fruitful, and thank you so much for being with us.
Thank you very much, Professor Hussam, for hosting us. It was a privilege and an honor for us. I hope it was useful. We learned a lot from your experience, and we hope to have the other webinars as soon as possible. But in the meantime, happy Ramadan to everybody.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, everybody.